May I request Dr. Juma to introduce Dr. Nilakshi and start the program, please.
So, hello everyone and welcome to today's webinar on geriatric assessment and care. For those of you who are joining us today, welcome. Global Pharma is a pharmaceutical company run by doctors with strong ties to Myanmar. We at Global Pharma believe knowledge increases by sharing, and to take this forward, we keep updated with the latest research and advances in the field of medicine and share this knowledge with doctors across the world in many ways, including regular webinars. I would now like to introduce our speaker, Dr. Nilakshi Mahanka. Dr. Nilakshi is an associate professor of medicine and head of department at Guwahati Medical College, Assam. She is trained both in India and abroad. Dr. Nilakshi is a WHO fellow in geriatrics and has trained in medical gerontology and palliative care. She is the author of many books on geriatric medicine and also on healthcare training for the elderly. Dr. Nilakshi has numerous publications on geriatrics and has spoken at numerous conferences worldwide. Welcome, Dr. Nilakshi, and thank you so much for doing this today. We really appreciate your time and effort taken for today's conference.
Thank you so much, Dr. Juma, for the kind introduction. So should I start with the presentation?
Please go ahead. There are almost 100 participants. I think we can go ahead. And the doctors have been waiting for quite some time.
Thank you so much. Okay. So a very good afternoon to all the participants and greetings from India. Namaste. Mingalaba. I think Mingalaba Shin. I hope I'm right in addressing, greetings from this part of the world to your end. So I'm very grateful to Dr. Juma and Dr. Venkatesh for asking me to speak to you all on a very important topic, which is essential for all of us and eventually will be needed and required by all of us at some point of time in our lifetimes. So it is all the more important for us to be well prepared to not only take care of the elderly population around us, but to ensure that, the services that are required are well in place so that when our time comes, we also can be embraced by the same services and the continuity of care continues. So today's topic is on a comprehensive geriatric assessment and multidisciplinary geriatric care. We have often seen in the medical education in our country, in India, there is a very little emphasis given on the differences in care in the elderly population when the students are studying the various subjects in their undergraduate curriculums and even in their postgraduate setups. Maybe now they are incorporating the exceptions that in an elderly, these are the things to be taken care of. But to say that geriatric care as a discipline, how we need to approach, it is very different from the clinical medicine that we are taught in our curriculums. It is different in terms of approach, not in terms of content. The same content is there, but how you're going to approach it and how you're going to apply it to your elderly population is a little different. And that is what is somewhere lacking still in our basic medical education. I presume I'm addressing a host of doctors from Myanmar, and most of you would be familiar with the terminologies. I'll try to keep it as simple and basic as possible. Maybe have the next slide, please. So I was just going through the statistics of the elderly in Myanmar, and I found out that in India, of course, in India, we have about 104 million geriatric elderly population who are, say, above the age of 60 years. And in Myanmar, I presume it is close to 8 million. When we look at the percentage of elderly population in the entire population in India, currently it is about 8.5% of our elderly population. So out of the whole population, 8.5% are in the elderly age group. And in Myanmar, it is around 6.5 to 7% currently. But this figure is going to rapidly increase in the next couple of years.
Hi.
because the healthcare facilities are improving, healthcare are developing, and with that, longevity is also going to come in. So we have some, let us look into some of the definitions of elderly care. So the United Nations, according to United Nations definition, the elderly age group is considered to be above 65 years. Talk about the gerontologists, who are the people who look after the elderly. For them, the classification is we can put them into three categories: the young old, the middle old, and the very old. So the young old would be people from around 60 to 69 years. Middle old would be around 70 to 79 years, and very old would be around 80 years and above. Irrespective of the age, we are talking about the chronological age, or the age which is, it's about how many years you are actually living on this planet, or I would say how many times you have revolved around the sun. That's called the chronological age. So these figures of 60, 65, 70 or 80 really do not matter too much when we have reached that age group, because what is more important is our biological age and our functional age. So when we talk about the biological age, it basically means what is the health status of at your cellular level. What is the biology of your cells and what is the age of your cells? So in fact, in our practical lives also, and probably even in your country, you might have seen that there are people who might be in their 80s or 90s, but they are extremely fit in terms of their general health. They could be walking or running or cycling or doing all kinds of activities. At the same time, you could have people in their 60s or very early 70s who might be actually having huge disease burdens and could be chronically having a lot of illnesses, and they could even be bedridden. So what is important here now is the functional age. The functional age depends a lot on the biological age, because if your cellular biology is good, you are going to have a good functional status, and your functional age would be dependent on factors like whether you are able to manage your day-to-day lives at whatever age. So age, the numerical figure should not really matter. What matters is how independently you can function, irrespective of your numerical or chronological age. So if that point is clear, I think you would understand that we are not looking at of course we do need the figure, like how old a person is, for various whether it's for research purpose, for academic purpose, for drug dosings, for deciding the side effects. So we do need the age per se, but more important is the functionality of the person. So we now come to some of the other terms that we use: normal aging versus successful aging. So very simple, normal aging is the universal process, physiological changes that occur with aging. So as we age, we all know that every organ system in our body will have some amount of degeneration. And along with the degeneration, the functional or the physiological capacities or the reserves in our bodies will also start declining. But that is normal aging. So what is successful aging? So when we say that aging is successful when we have some modifications in our behavioral processes to achieve the best possible outcome of aging. So we should be aiming at successful aging so that we can make those changes from now itself so that we can achieve the best possible outcome. Next slide, please. So normally we see that in youth we run into difficulties, but in old age it is the other way around, and difficulties would start running into us. And we all know that aging is completely inevitable. It is an irreversible process. You can only move forward in age. You cannot move backward in age, unlike the movie of Benjamin Button, but that's fiction. I mean, we have to be realistic here. And so the physiological age is determined by the function. So functionality is something that I'll be talking about. I'll be using the word function quite a lot. And it basically determines how well you can function on a day-to-day basis. to live in your own homes independently and to live in your own communities independently. So we expect that people live healthily in their communities as well as, as at their homes. There is a very simple rule or formula of thirds with regard to how well a person can function. And is it like in our country, we often see that, people who are above a particular age are asked to, not do certain work or household chores because they are told that you are old, so you need to sit down and just, rest. So that actually can cause a lot of decline in functionality. So we have a rule of thirds where in an elderly person, if they decline functionally, we have to realize that this decline in function is not just because of their chronological age. It could be actually either because of disuse. That means they are not using their, uh, limbs or the muscles, or they are not doing the activities. One third, of course, could be because of some chronic or ongoing disease process. And one third only can be attributed to the degenerative changes of aging. So, keeping all this in mind, we have to realize that we cannot blame our chronological age for a decline in our functionality. So, we need to see that our organs, including our neuromuscular systems and our, higher mental functions, they are all kept in constant use so that they function at their optimal level, despite some amount of degeneration or disease that might be there. We now come to what is called as comprehensive geriatric assessment. So it is very important that when you are handling an elderly in your clinic, in your chamber, in your community, or in your hospital, you need to look into all the aspects, not just what are the chief complaints and just give some medication based on the chief complaints. So comprehensive geriatric assessment is actually the right way to go, but the only flip side of it is that it is a very exhaustive process. So a proper comprehensive geriatric assessment could take anywhere close to 40 to 45 minutes. In Western countries, they would spend more than that, maybe 90 minutes to do a proper comprehensive geriatric assessment. To have this kind of an assessment, even in a country like India, is extremely tough, especially when the doctor is very busy in his OPD and has more than 30, 40 patients to see. It is not possible for the clinician or the physician to do the whole assessment. And this is the reason why we need what we call a team. So coming to the basic definition of comprehensive geriatric assessment, it is a multidisciplinary diagnostic and treatment process that identifies medical, psychosocial, and functional limitations of an elderly in order to develop a coordinated plan to maximize overall health with aging. So we can see that there are different domains. We will come into all this in details. So the comprehensive geriatric assessment is a systemic evaluation by a team of health professionals to identify treatable health problems for better health outcomes. This could be both immediate as well as long term. Now, the question is that how do I spend 40 to 45 minutes on my elderly patients? In that case, I won't be seeing more than 2 or 3 patients in a day. Yes, it is difficult, but you can have your team in place to do all the preliminary work till it is seen by the doctor. So the doctor should actually receive the whole profile of the patient with all the assessments done in order to make the proper management or treatment plan. So the patients or the elderly who need comprehensive geriatric assessment. So one is, as you are increasing in age. Secondly, if you have multiple comorbidities, like you might be having a heart failure or an obstructive airway disease, or you have dementia, or you have falls, like repeated falls, or you have depression, or you need to change the living situation of an elderly. Somebody who was living independently now has to shift to his daughter's home for better care, or a person is repeatedly going to the hospital for some issue or the other. So these are certain groups of patients in the elderly subsets who need to have special focus on. So let us see who does not need a CGA, who we don't have to do a CGA for these two extreme ends of the patients. So one end is the terminally ill patients, the ones who are completely bedridden, or who are having severe dementia, or who are completely functionally dependent on their caregivers. It is no point doing an exhaustive CGA on such a patient. At the same time, it is no point doing a comprehensive geriatric assessment to a very healthy elderly. He might be 65 years, but he has absolutely no comorbids. He's living a completely healthy lifestyle. He is functionally independent. He's probably even working. So those patients also, it is no point doing a completely exhaustive CGA. So it is the middle group of patients who actually require a CGA. So let us now come into how are we going to assess these older people now, the ones who need a CGA, and what are the tools by which we are going to assess that. So there are various domains of assessment of the older people. One by one, if we look into it, so you have the physical or medical problem list along with the comorbid list. So it could be an acute problem now. So the patient has come with some problem to you, but you also have a lot of other comorbid conditions which need to be looked after. So patient might have come with a fall, or the patient might have come with some incontinence, but the patient has a hypertension. You found that his blood pressure was also very high, his sugar was not controlled. So those are the things which the patient did not tell you. But that is for the doctor to find out and also take care of all those parameters. Second one is functional assessment. So functional assessment, we commonly follow some tools. These are all available on the net. You can search and find out. So you have functional assessment tools like the activity of daily living score, the instrumental activity of daily living score. Then the third domain is the mental domain. So you have the functional domain is largely dependent on your physical, health. But the mental domain is the cognitive domain, and to assess, because we know that with old age, a lot of cognitive problems will start developing, including diseases like Alzheimer's disease or dementia due to other reasons, or there could be some depression. So I think there are two things. One is like MMSE is the mini mental scale examination. If we had any neurologists in the group, they would definitely know, or any psychiatrists in the group, they would also know. Then we have some specific tools to measure the depression, which is called the Geriatric Depression Scale, like the GDS is Geriatric Depression Scale. So if you look at search in the net, you will find the entire detail of the instruments that I'm saying, which can be used in your day-to-day practice to find out whether these patients are having any kind of memory impairment or whether they are suffering from any depression. Thereby, is there any decline in their cognitive function? The next domain is, these are things we never think about, but they may be small matters, but they're very important to attain optimal health. The social and environmental checklist. So it is very important to know the kind of surroundings of the environment that he lives in. Like, are there too many obstructions? Is there a lot of clutter in his house? Is there a slippery floor? Those are the things that we have to see in the environmental checklist. The next is the nutritional status. So the nutritional status of a person is assessed by tools like mini nutritional assessment scale. So these are all again available on the net, and we can find out who is malnourished or poorly nourished, and they are another subset that should be taken care of separately. And another very important thing I'll be talking about is falls. So we need to find out, I think very often you might have found a lot of your elderly patients presenting to you just with a fall. A fall is something not, I mean, we just think it's a fall. I mean, just, it's a simple word, like it's fall. But there is a whole dimension into falls in elderly. In fact, we have huge chapters and even textbooks only on falls in elderly. That important it is. So right from, the causes of fall, the risk factors of fall, the intrinsic, extrinsic factors of fall, how do you assess, how do you interpret, how do you manage, how do you prevent, and how do you tackle. So it's a big, big chapter altogether. So we have something called the GUGT, which is called the Get Up and Go Test, GUGT, and that is to find out if the person has a risk of fall. I will be explaining that shortly. And then we can assess the overall quality of life using WHO tools for assessing the quality of life on of an elderly. So patient team to do all this, like, who's going to assess? It's not possible. The doctor will say, I don't have time for doing all. I cannot be asking about his home environment and whether he's having a slippery floor, or whether he has enough lighting in his bedroom. These are not my work. Yes, certainly, and there are different domains which are being going to be tackled by different teams. So that is why geriatric is not an isolated process. So the physician deals with the medical part of it. The nurse assists in the medical assessment. The nurse can often do a lot of preliminary nursing assessment. The dietitian can do the nutritional assessment. The psychologist can do the cognitive assessment, that is the MMSE and the GDS, as I have said. The social worker can do the social and environmental assessment. The physiotherapist is the one who does the functional assessment, that is the activity of daily living and the instrumental activity of daily living. And the occupational therapist can also help in the functional and environmental assessment. And you need a pharmacist to actually see the drug list and find out whether there is any duplication or polypharmacy. Next slide. So, how do I get my team ready? It may not be possible for me to find so many people, because maybe we don't have trained physiotherapists, we don't have enough trained psychologists, we don't have enough, social workers. So a lot depends on very good networking. You need to network with these groups, and I'm sure if you network, you will find people who are more than willing to come and be a part of this team. I did start by spending 40 to 45 minutes on my patients, and then gradually I got 2 or 3 people, and then we found that we could actually do some of the work together, and a lot of this, data recording, capturing of the data could be done by our assistants, social workers, and it is possible to. But we may not have a team of 7 or 8 people, as I have listed in the list, which is the ideal situation. But we can have a team of at least 3 people, and that itself also helps. So sometimes I am not just the doctor; I'm also acting as a nurse, or I'm also acting as a counselor. So if I don't have a counselor with me, so some of the things we do try to cover up, but it would be nice if we have all members of the team. So if you can see the medical assessment, you have to see the problem list, the comorbid list, the medicational review, and the nutritional assessment. In the functional assessment, the domain of medical, ideally to be done by a physiotherapist who can see the activities of daily living, the instrumental activities of daily living, the activity and exercise status of the patient, the gait and balance assessment of the patient. So this is a little, it is more or less similar to what we learned in neurology, how to test the gait and balance when you are doing the peripheral nervous system examination. So it's only that it is more focused on the, crude things like, the balance, maintaining of balance, and, gait and walking, and any tendency to fall. So these can be done by much simpler tools rather than going through the whole process of CNS examination, which we normally learn in our MBBS course. So the psychological assessment, as I said, ideally to be done by a psychologist, but if you don't have one, you can train somebody to just ask the questions, which is very simple. The MMSE tool is a very simple tool. We all have used MMSE at some point of time. Then the geriatric depression scale also is a 15 questionnaires. These are very simple. So basically, these assessments can be done by the various team members. And if you don't have team members, you can train up people who can do these assessments, because the questions are very simple. It's all usually in yes/no format, where you can give the scores and you can find the total score, and that gives an overall assessment of how we are going with identifying the problem list of the patient. So coming to the medical assessment, here it's very simple. Just like in, we know the chief complaints of the patient. Why have you come to my clinic? What's your main problem? So that's the chief complaint. But don't forget to ask about the comorbids. Very often in clinical medicine, we are taught about the past history, and we put things like hypertension, diabetes all in the past history. These things are not in the past history. They are ongoing. They need to be seen and assessed and known whether they are under control or not, because they have long-term implications on every other organ of your body. So osteoarthritis, these are things, degenerative changes, they're going to stay. Parkinson's disease. So you identify thyroid disorders, try to find what are the comorbids and whether they are within control or not. So the major idea is to focus on the acute problems, but also address the comorbids and see whether they are under control or not. Then you have to do a good medication review, because we often see elderly patient taking a lot of medicines, over the counter pills, as well as visiting at least 5-6 doctors and taking prescriptions from each, not telling the one doctor that he's already got one prescription from another doctor, and then having duplicating medicines. Apart from that, they are very keen on trying different kinds of alternative medicines. I always feel that alternative medicines, there's a huge scope out there, and as long as it is scientifically established, it can definitely be taken by the patients, and sometimes patients do pretty well also. But without evidence, it becomes difficult to actually medically say that it's okay for you to have that, because we sometimes don't know what side effects they might cause and what kind of interactions they may have with the medicines prescribed by a clinician or a physician. The nutritional status becomes very important in deciding the patient's ability to withstand treatment, and also the response of various ailments on his general condition, because the recovery from various illnesses depend largely on how good a nutritional status you have. What is your backup system like? If you already are poorly nourished, then when illnesses happen, your chances of recovery also become very slow and difficult. Vision and hearing are two very important domains of elderly, which we often forget to ask, but I would say that they are the priority number one for going ahead. When you are assessing an elderly, please find out whether the patient has any visual or hearing impairment, because these two senses are most important for the functionality of a patient. Again, I'm using the word function. When I say function, the ability of a person to handle his own life in his home and in his community. So if you find a visually impaired person or a hearing impaired person, they will definitely go into isolation. They will not like to venture out. They will feel afraid. They will be apprehensive. So these are the things that need to be corrected, because these are the senses which help us move around or mobilize us in our environments. Then if the patient, these are the common problems that we see in the older people: arthritis, respiratory problems, malignancies. Malignancies are also like intercurrent, they are there along with a host of other problems: high blood pressure, diabetes, strokes. Patient might have recovered from a stroke and is left with a paralysis. There is a residual damage there. Coronary artery disease. There could be anemias which have not been addressed. There could be depression, loneliness, a very, very significant factor in our population, especially the urban ones. So in urban elderly, we are seeing a lot of depression and loneliness, and a decline in the quality of life. Elder abuse and neglect, it is an issue, less spoken about. It is basically what we see as abuse is only the tip of the iceberg. I have done a paper and published a paper on elder abuse, and we found more than 11 to 12% of the patients that we uh, examined or evaluated, they have had received abuses of various grades in their interim periods. So it's very important to see. Sometimes even caregivers are abusers. So that's a different chapter altogether. I'll not delve into it, because here I'm just wanting to highlight the important things that we need to know. And this is a very important slide. I would ask all the doctors and participants to focus on these 4 points. You have, we call them the geriatric giants. So any elderly could present at any point of time with any of these 4 symptoms, which need not be primarily due to a disease in a particular system, but could be because of any problem in any part of the body. For example, when you have an altered sensorium, don't just think about neurology. It could be an infection somewhere. It could be a urinary tract infection causing an altered sensorium. If you have a fall, don't think just about an orthopedic problem. It could be even a depression causing a fall. I have a study which is published on the correlation of falls with depression in elderly. And we found a statistically significant data to say that depressed patients are having a higher tendency to fall. Incontinence. Don't think just about a kidney problem or a urinary tract problem in a patient who suddenly presents with incontinence. It could be because of a pneumonia in the lung. So you can see how varied the presentation can be. You can have a problem in one part of the body, but the presentation is somewhere else. This is not something which we are normally taught in our MBBS curriculum. Because when we talk about incontinence, think of the bladder, think of the ureter, think of the kidney. So that's what we have been taught about. But in elderly, all this does not apply. Everything is changed. Incontinence could be because of anything, like even a stroke or a cardiac event could present with incontinence. Immobility. A person who was walking till yesterday suddenly becomes immobile or has a difficulty in getting up or moving, whether it's quadriparesis or paraparesis or hemiparesis or any kind of immobility. If it occurs, that is a significant factor, and it could mean anything. So you have to see all the systems. If we look at falls, again, I'm stressing on falls, very common problem. The statistics says that in patients age 65 and above, 1 out of 3 people fall each year. In those above 72, each and every patient would fall at least once in 2 years. So imagine that you have crossed 70 and you're likely to fall in the next 2 years once. And in 80 and above, you're likely to fall at least once every year. So that's a huge figure out there. And we need to be, taking all precautions that it doesn't happen, because once it happens, it's just a downhill course for many. So medications, yes. So often you'll find, as I said, I've already touched on this, patient visit various doctors, they would take various pills, lot of medicines, duplication of medicines. Somebody might have prescribed an pantoprazole, another doctor prescribes omeprazole, somebody has given him a ranitidine, and they're all doing the same job, but only adding to drug interaction. And second is that too many pills make them forget whether they have had their right pills or not. Did I have my pressure pill? And he simply has it again. Side effects of drugs and drug interactions, these become very important. So the dictum is that start low, go slow with elderly. Sometimes it's better to start with half the recommended dose, see how it goes for a week or so, and then slowly escalate it to the fully optimum dose. Do not just start with the highest possible dose. That's not the case with elderly. But yes, this may not be true for antibiotics and all, which require to be given in the particular recommended dose. So I'm talking about the chronic problems which might require. Coming to assessment of function, largely in the domain of a physiotherapist, where they would look into the activity of daily living score. We use the CARD score or the Barthel score. These are all available on the internet. You can Google search and get them down. The IADL is called the Instrumental Activity of Daily Living. This is a score which measures your ability to live independently and sustaining yourself in a community. That means whether you can go shopping, whether you can go to the post office, whether you can handle your bank details, whether you can use a public transport, whether you can do your laundry. These are the things which tell us about the IADL. Whereas the ADL was only about your own self-care, mainly about your own self-care. Then your activity and exercise status, how active are you? Are you just sitting idle and, rusting out all your muscles and joints? Gait and balance gives us an idea about the strength of the musculoskeletal system, and also tells us about the probability of fall. And the most simple test is the GUGT, get up and go test. You can find it again on the net, and it will tell you that this patient is at a higher risk of fall. And as I told you, vision, hearing, and dental status, all these are important in elderly, more important because that is how they will interact with their surroundings. So this is the just rough this thing about the time get up and go test. You can make the patient sit on a tool, begin the timing. The patient will rise from the standard chair and walk on a line approximately 10 feet away and turn around and return to the chair and again sit on the chair. And you have to use the stopwatch to just take the timing. If the timing is less than 10 seconds, then it means that the patient is fine and his risk of fall is minimal. But if a patient takes more than 30 seconds for a 10 feet walk going and coming back, it means that he has a very high risk of fall, because the time indicates that there is a risk in which the patient is walking and taking so much time. And between 10 to 30 is the mid group, which needs to be further assessed for what is the reason for the increased time get up and go test. Next slide. Next slide. Okay. So we have this is to be done by the psychologist in the team. And sometimes when the psychologist, you don't have a psychologist, then you can quickly do the something like the clock drawing test, which will help you, find out how bad or good is his psychological status. So MMSE, mini mental scale, is a score out of 30, and tells us, whether the patient has dementia or mild cognitive impairment. Anybody having a score below 20 could be having dementia. 20 to 24, it is labeled as mild cognitive impairment, and 24 and above could be normal, just age-associated memory impairment. Along with that, it's important to do the geriatric depression scale. Why? Reason being is, if your MMSE score is, say, somewhere around 24, and you do a GDS also, and the GDS score says that this patient has severe depression, then the patient is not actually having dementia or mild cognitive impairment because of Alzheimer's or something. It is entirely due to his depression. So you treat the depression, and after that, when you follow him up, you will find that the MMSE improves. So it clearly indicates that you are dealing with a reversible situation. Clock drawing test, as you can see, the figures here tell you that when you ask an elderly to draw a clock, which everybody knows, you can find that there could be a variety of drawings, and that precisely tells us where his cognitive status is. So somebody who's done a perfect clock drawing, as in the first figure, which is, we can consider that to be okay if he's asked to draw 2 o'clock and he puts that, say, 10 minutes to 2, it's fine. That goes well. So these tests actually can differentiate between dementia, delirium, and depression, which are the 3 important Ds in elderly. Those who are interested, neurologists, psychiatrists, or psychologists, could delve into this area more and find out how we can actually differentiate. So these are some of the activities which we do. The pictures in this presentation, many of them are our own pictures about the work that we are doing and how we do it. So you'll see us in some of the pictures too. So it's nothing great, actually. It's just spending some time with them, and it just gives you a feel-good factor, and it gives them a big boost. So you can have informal support groups or family groups and friends, and go and spend some time with an elderly anywhere in your community, or in some daycare home, or in any elderly care home, or any lonely elderly you know of. Just go and pay a visit. If there's a volunteer, or you can train up a team of volunteers, well and good. If you can't, just do what you can. That's it. So if each of us can think like that, then I think we all are volunteers at some point of time. So this, of course, these are not this is not our activity, but I just to give an idea of how you can keep the mind and body healthy, eating good food, engaging in meaningful activities, entertainment, and of course, social teams. So that's very important to keep you healthy in whichever part of the world you might be in. Coming to the environmental assessment, this is often done by an occupational therapist who is a part of the physiotherapy team, and their job is to see what is the home safety level like. So this is again very important for fall prevention. I won't go into the details. So you have a fall prevention checklist where you can go into the homes of the patients and find out if there are risks of fall, which can be modified, like, the toilet, the lighting, whether there are carpets, whether there are slippery floors, whether there are door unnecessary handles, which, or, some obstructions which can cause a fall. So we should use accessible local resources to look into all these factors. Next slide. So coming to the summary of evaluation, a geriatric assessment team creates a personalized set of recommendations after assessing the patient. So the medical history will profile of current medications, functional status, cognitive impairments, depression, gait and balance, incontinence, chronic conditions, and the social and financial support groups. All this comes into the summary of evaluation. Next slide. So I do hope that, all the doctors and all the medical fraternity of Myanmar could understand the overview of a comprehensive geriatric assessment, which I have just completed in the previous slides. And I'd like to take you through an example so that it makes our work easier to see how we'll go around when we get a patient. So let us see. Here's one Mr. B, who's a 70-year-old male, married, lives with his spouse, educated, postgraduate, and living with spouse. His 2 children are away. One is in Bangalore and the other is in South Africa. So he's basically on his own. And his caregiver is his wife. That's very important. When you're addressing a patient, you have to know who's the caregiver in this patient. So wife is the caregiver. She herself has hypertension and osteoarthritis. So we have a wife, spouse, who also has her own share of problems. So we often undermine these things, but they are very important. And what is the source of income? This becomes a big issue with older people. In our country, we have only 10% of our population who gets a pension. 90% don't have pension, and that's the reason why they rely on things like either house rent or support from their children. So, that is a very important factor. We have no financial planning for our old age, very minimal financial planning for our old age. And that, I think, is another whole domain of economics that needs to be looked into if we want to uplift the positions or conditions of the elderly. So what was Mr. B's presentation? He had he had pain in the low back and right hip following a fall 3 days back. So very common situation. So he has some local swelling and tenderness, and an X-ray was also done, which did not reveal any abnormal. There was no fracture or anything, just some swelling in the local part. Now let us look at his morbidity profile. If you look at his morbidity profile, if you ask him what he thinks about his own status, he says it's like plus minus, it's just about fair. And if you ask him about his vision, he says it's very like he can't see very well with his specs, and he's been using the same spectacles for the last 20 years. So that, from an educated individual, is pretty surprising, because one needs to have, after the age of 60 or 65, at least an annual vision checkup is important. So this person was somehow just going on like that with his old specs. Hearing is normal, speech normal, bowels were constipated. He has some occasional incontinence, he says, and he has some disturbed sleep. And he has a lot of joint pains. He's a known case of rheumatoid arthritis. And he has history of 3 to 4 falls in the last 6 months without any fracture, thankfully. And his comorbids, he's a hypertensive. For the last 35 years, he takes his pressure medicines very regularly. He's a diabetic for the last 20 years, but on irregular medications. He is having COPD also, again, irregular medication, and rheumatoid arthritis. This is one disease. He's very regularly taking his medication, but no follow-up for more than 5 years. He's not taken any follow-up for that. He's just taking all the medicines he was prescribed 5 years ago. And he has some benign prostatic hypertrophy, and he's taking some medication, including some alternative medicines. Next slide. He's an ex-smoker who stopped 1 year back, chews tobacco, and also for several years, and also consumes alcohol 2 to 3 times in a week. Next slide. His oral cavity, his teeth and gums are very unhealthy. He has multiple caries and a suspicious ulcer on the left cheek. His skin is dry and rough. Neck glands show level 1 cervical palpable firm 1 centimeter node. And JVP is not raised. Temperature is normal. Pulse 80 and blood pressure 150/70. Respiration rate 18 per minute. No pallor or icterus or cyanosis present. His gait is abnormal. He has he has grade 1 clubbing. Yes, next slide. His gait is abnormal. He has a tilt towards the right. There is no kyphosis or scoliosis. He has some pitting edema around the ankle, which increases on sitting for long duration. Local examination, there is a mild swelling over the left hip area with some tenderness, but no ecchymosis and some restriction of movement with SLR of 60 degrees bilaterally. So other systemic examination, respiratory system shows a hyperresonant note on percussion with diminished vesicular breath sounds without any rhonchi or creps, which is very common with emphysema. So he has a barrel-shaped chest. Cardiovascular is fairly normal with no murmur or any added sound. And CNS function is also normal. Motor, sensory, deep tendon reflexes, plantar is flexor. Abdomen is soft, but there is a mass palpable over the left iliac fossa, which could be because of loaded colon. If you look at his drug list, you will find that he is having all these medicines. Some of them regularly, some of them irregularly. Amlodipine, metformin, glimepiride, omeprazole, hydroxychloroquine, methylprednisolone, tamsulosin, levocetris, montelukast, terbutaline, a lot of medicines, and some alternative medicines too. And his blood counts are fairly normal. Total count, hemoglobin is 11, platelet is normal, ESR 30, create is 1.1. Random blood sugar is around 150. Electrolytes are normal. A1C is 8, which shows that the sugar is not very well controlled. And his creatinine clearance is 58 ml per minute. Bilirubin, AST, ALT, slightly elevated AST, ALT levels. Uric acid 6.8. Cholesterol is 200. Triglyceride 180. ECG shows some left ventricular hypertrophy. Ultrasound shows grade 1 fatty liver with a BPH, and X-ray shows emphysematous change, and X-ray of spine and pelvis were found to be normal. His psychological assessment showed a mini mental scale examination of 22 out of 30, which could mean early dementia or even depression. We are not sure which one. But his GDS shows that he has moderate depression. His score is 6 out of 15. And the clock drawing test was normal. So could be he is having some amount of depression, which is causing a decline of the MMSE. We now go to there are questions asked about his home safety and his house. He's an educated and he's a pension holder, retired government person. He lives in a concrete house with some garden and outside path. Floors are not slippery. There's no sign of neglect in his home. Well ventilated house, lighting is adequate, no clutter, no rugs and carpets, and there's no overcrowding. So this is the home assessment of this patient. The ADL, which I told you is an activity of daily living tool, shows a score of 16 out of 20. I will not go into the details, but you just need to know what are the things that are seen: bowel, bladder, grooming, toileting, feeding, transfer, mobility, dressing, climbing stairs, bathing. So whether he's independent, partially dependent, or totally dependent on these. On this basis, the scoring is done. And the get up and go test was 24 seconds. And the instrumental activity of daily living, which tells you about whether you can handle your life outside of home or do more complex stuff. So he can dial his telephone, use his telephone. He rarely goes out and shops for small purchases earlier before he had the fall. And household chores are handled entirely by his wife, who's also hypertensive and osteoarthritic. We shouldn't forget that. The mode of transportation, he prefers to stay at home. He's responsible for his own medicines, able to take, and he's taking it according to without taking follow-ups also, but he's taking it all the same, and he handles his own finances. Yes, next. So if we look at his problem list, now we find that his main problem list is the soft tissue injury and the pain that is following that, and that can be managed by following the RICE protocol, which I think everybody knows: rest, immobility, compression, and elevation, along with some analgesics. Because he doesn't have a fracture, we don't have to worry so much. Some amount of immobilization is good enough. And rest. Disturbed sleep, because probably pain relief will cause the sleep to be better. Constipation, we can have some diet modification and laxatives in his diet. And occasional urinary incontinence, we do need to do a culture to rule out urinary tract infection. And because he has BPH, so BPH can trigger residual urine and some infection. Pedal edema could be because of drug induced, because he's on amlodipine. It is a known notorious for causing edema. Physical inactivity might also be a reason for the pedal edema, or it could be some amount of congestive cardiac failure or a diabetic nephropathy. So all these things need to be worked up. So comorbids and their management, we need to see that the pressure is 150/70. So overall, it's okay. We don't need to reduce pressure too much in an elderly. We have to remember that up to 160/90, actually, we can safely keep them okay. If it goes above that, then it needs more stringent monitoring. Do not try to reduce the pressure too much in an elderly. There are studies which have showed that stringent control of blood pressure can actually increase the risk for brain hypoxia leading to dementia. So need to keep that in mind. At the same time, it shouldn't go shoot up also. So diabetes needs stringent control. For his COPD, it's fairly stable as of now. Some amount of regular pulmonary physiotherapy will do good. Rheumatoid arthritis, very important to review his huge drug list, including hydroxychloroquine and methylprednisolone, which he seems to be having without consulting his rheumatologist in the last 5 years. Pedal edema, we can stop the calcium channel blocker, that's amlodipine, and see how it goes, and maybe replace it with another antihypertensive. Some lower limb exercises and limb elevation after he recovers from the pain of his fall. And he has a fear of falling. So fear of falling is also another important situation for which the patient starts isolating. They don't go out anymore because they've fear that they're going to repeatedly fall. So some balance and training exercises can be done by the physiotherapist. Depression can be dealt by adequate counseling, networking with support groups. I have not written antidepressant drugs there purposely because I won't personally want to add another drug to his whole list of drugs. So I think we should use other methods to deal with his depression. Other incidental findings which we may not have thought to be very important, but actually are very important. So you can see that, some of the smallest things might be the most important thing. In geriatrics, that's the beauty of geriatrics. Very small shifts in corrections can cause a miraculous change in the overall well-being of the person. You don't have to go for some rocket science technology. Maybe you just correct his spectacles. You can find out by going to the ophthalmologist and getting, because he has been wearing the same specs for so many years, his vision might be the only reason why he's falling so many times, along with the rheumatoid arthritis and all. Of course those are there, but we can't forget all those. But at the same time, something as simple as correcting your specs can bring a whole new change in your lifestyle. Reduce the number of medicines, streamline your medicines, reduce duplication, evaluate the ulcer in the cheek. That is something we should not forget. It could be a malignancy, and most likely it is a malignancy. So that needs to be addressed. So case summary, if we see, address the acute problem, pain, recurrent falls, handle the comorbids well, streamline the medications, avoid duplications, physiotherapy interventions to handle the acute problem as well as prevent future falls and newer problems, psychosocial interventions to tackle depression, loneliness, and other dementia-like features, nutritional guidance, home environment. His home environment is pretty okay, and screening for the malignancy and evaluating the cheek ulcer and the neck node. So tips to improve the quality of life. This is general for all older people. Regular exercise, even if you don't have any problem, don't forget these very important tips in your lifestyle, which can bring a huge positive impact in your day-to-day functions and day-to-day performance and your productivity. You can find amazing results with that. So regular physical activity with some yoga and meditation, which I think is very strong in your societies. I'm very sure we have a lot to learn from regarding meditation from your societies actually. And I myself am personally very keen and interested in these areas, and I'm delving more deeper into these areas and their beneficial effects on the human mind and the body. Good quality sleep, very important. Training thoughts for positive well-being, channelizing your creative energy, engaging in meaningful activities and pursuing hobbies. Even if you're old, do not hesitate to learn something new. It's always good to learn something new or bring back something which you had learned in your childhood and do that now. So this is the time, whether it's music or, gardening or any other, say, some learning a new instrument or, a new language or some poetry writing or anything can become meaningful. It gives you a sense of meaning. And participating in social and community activities, and again, spiritual engagement, very important for in these times and to move forward. And I think spiritual, uh, it's an entirely different dimension, and when you step into that domain, I think there's no stopping you from just moving forward and see how it unfolds, because it doesn't have a finishing point. It just goes on and on. So it's amazing how some amount of spiritual involvement can bring so much of difference in your quality of life. So I thought it was mandatory to say something about COVID times, but I think there's enough on the media and the televisions. So I have actually nothing more to add. And because very interestingly, yes, I must share this story with you. I went to a park where I regularly visit. I used to go for morning walks, but with COVID, the park got closed. And in that park, we had a group of elderly who used to come every morning, and they used to do some regular yoga and exercises, and they had a laughing club, and they would do some prayers, and then they would generally have fun for about 1.5 hours. And I was very close to many of them, so I would watch them from a distance and do my exercises and walking, and I would come back. So for about 8 months, the park was closed. And when I went back to the park just the other day, 2 weeks back, and it was a delightful reunion with so many of those senior citizens. And then one of them said that, do you know, doctor, we lost 3 of our friends in this COVID times, and they died because of COVID. No, and they died. They passed away, and they did have COVID. Then I asked them, was it COVID? They said yes, they died because of COVID. But I think it was not the COVID that killed them. It was the isolation and locking them up in their rooms which actually killed them. So it was a host of other problems that sunk into these patients. They had the COVID, but they did not have the immune system strong enough to fight the COVID. And that's what killed them. So this opening of the park is such a breather for us. And, we feel that, we are way more healthier and happier when we have these spaces opened up for us, where while we mandatorily, of course, will follow the rules and regulations that are set down. So physical distancing is important, not social distancing. So it's you don't have to hug somebody, or you don't have to hold somebody. You can still interact maintaining a physical distance. Mandatory masks, of course, if you're exercising, don't wear the mask when you're exercising, but you must otherwise wear the mask. Avoid crowds wherever the crowds. Avoid hand sanitization. We all know all this from the WHO protocols. And sometimes if you don't have any place to go, you can do a lot of exercises. Nowadays, you have so many different options of exercises just sitting at home. There's something called a chair yoga. You can just sit on a chair and do a whole lot of exercises out there. Optimally utilizing your resources at home, healthy eating, again, meditation, exercises, continue them, and utilizing digital tools like today. Today is an example of how 2 countries we are talking about taking care of our elderly. So this is what, we should use technology definitely to improve, our quality of lives, but we should not let technology, make us forget what life actually is. So let us not use technology, that technology starts controlling our lives, but we need to use technology in a way that we can control the technology. So with these few words, I would like to thank all of you very much. And I'm really grateful once again for giving me this opportunity. I hope was able to clarify a lot of aspects of elderly health care with my whatever little experience that I have. And I thank you very much. Thank you so much.
Thank you, Dr. Nilakshi. Thank you so much for the presentation, and you have dwelled into the subject with so much of clarity. So thank you so much. I think the audience has a couple of questions for you.
Thank you. Yeah.
Can I ask the questions?
Yeah, sure.
Okay. One is from Dr. 1 minute. Dr. Mimite wants to know, she has 3 questions for you. Elder people are more prone to fall. Is it dependent upon the aging or underlying disease? Why elderly people move slowly? And most elderly people get dementia can be prevented. And she would like to thank you for your excellent presentation.
Thank you so much. All 3 very important questions. So the first question was whether can you just
prone to fall? Elderly people are more prone to fall. Is it dependent upon aging or underlying disease?
The risk of fall in elderly is because of several factors, and we can often divide them into age alone is not the factor. Age is just one of the factors, the chronological age, but the various other factors, we can divide them into extrinsic factors and intrinsic factors. So when you talk about the intrinsic factors, it is because of disease. So intrinsic factor, when you talk about disease, it could be neurological disease, it could be like something like Parkinson's disease, it could be something like Alzheimer's disease, it could be something, a post-stroke scenario, it could be a neuromuscular disease like an arthritis, or an osteoarthritis or a rheumatoid arthritis. It could be because of a cardiovascular disease also. Maybe a cardiac event can cause a fall. So every system, basically, there could be diabetic neuropathy, peripheral neuropathy, which can cause a fall. So these are diseases or intrinsic factors which, because of poor control of the conditions, it makes the patient more prone to fall. Apart from that, we have a lot of extrinsic factors which can cause a fall. Amongst the intrinsic, of course, vision and hearing are again very important. As I told with the example also, even people with impaired hearing have a tendency to fall because they can't hear, and they are kind of always worried that there could be something that they have unexpected is going to happen, and therefore their gait also becomes unstable. So studies have shown direct relations of hearing impairment with falls. Again, when you talk about the extrinsic factors, I've laid a lot of stress on the home safety environment. So the person could be living in an environment where extrinsic factors also can make the person more prone to fall. In our homes, mainly, we are seeing a lot of clutter. There could be a lot of clutter in the house, which where the patient may bump into, or there could be poor, inadequate lighting. When you're going from at night time, commonly old people fall when they go from the bedroom to the bathroom at night. So poor lighting and maybe some rugs or something on the way, which might have caused them to slip or trip over that. So we have to look into all factors. It's not just age, certainly is not the alone factor at all. So that is the first question. The second question.
Why do elderly people move slowly?
Yeah, again here elderly people move slowly because of mostly because of the burden of diseases. So multiple diseases, it could be and of course some of it is degenerative. So we know that with degeneration we can have osteoarthritis of the knee joints, of the hip joints. That's a very common condition where many older people will start moving slowly. But along with that, the patient also has, say, some early Parkinson's disease. The patient also has a long-standing diabetes with some diabetic neuropathy. So these are, or maybe the patient also had a mild stroke, we know multi-infarct dementia, which can actually cause mini strokes over a period of time. And this can cause some amount of spasticity in the limbs. And that can cause some amount of spastic gait, and therefore they start moving slowly. So slow movement could be because a host of multiple factors. Also, if their vision and hearing are impaired, they will start moving cautiously. So that again, because they have something called a fear of falling. Anybody who's fallen once or twice in 6 months will have a condition which is called as fear of falling. So they will isolate themselves, they stop moving, or even if they move very, very slowly, so that they may not fall or trip again. So that's the reason why they usually move slowly. And the third question is about dementia.
Yeah, most elderly get dementia, can be prevented.
Dementia is again a very, very big chapter. It's very difficult for me to give you a one-word answer. I would say again, it's very important. We often may label something as dementia, but it could be one of the 3 Ds. It could be actually depression also, it could be delirium also. So before labeling him as dementia, please exclude delirium, please exclude depression. What is delirium? Delirium is an acute confusional state, which usually will reverse in less than 6 weeks' time. So in 6 weeks, it could be because of hyponatremia, it could be because of hypokalemia, it could be because of a hypothyroidism, it could be because of a vitamin B12 deficiency. There could be so many treatable causes of, altered sensorium. So if it is a reversible cause, that is delirium. That's not dementia. But if it goes on for more than 6 months and we have not been able to identify a rectifiable cause, then that becomes dementia. And then, of course, before labeling as dementia, we'll have to completely thoroughly investigate and evaluate the patient, including CT scan and MRI, to rule out conditions like maybe a subdural hematoma, or maybe a small brain tumor somewhere, or maybe some stroke. So these have to be ruled out before we can label the patient as Alzheimer's. But yes, the incidence of dementia, which can be because of Alzheimer's or multi-infarct dementia or various other dementias like Lewy body and frontotemporal dementia and a host of other types. So usually we did a study in Assam, and we found again close to 15% of elderly above 60 had dementia. So that is a high number, and the numbers are definitely increasing. We are getting more and more patients of dementia with age, yes. I don't know whether it is because of diet, and you're asking about prevention. It's once it occurs, if it is Alzheimer's, you cannot do anything about it. Usually there's a type of Alzheimer's which can occur very early onset dementia. That is the more dangerous type. That could be because of a family history also. So they present early. They may present in their late 50s also, or early 60s also. So I don't know if anybody has watched that movie Still Alice. There is I think it was Julia Roberts, or I forgot. Still Alice is a movie which beautifully portrays Alzheimer's disease, which started very young with genetic mutation. So there are these causes of genetic mutations which can cause Alzheimer's. There could be dietary factors. There could be, it is seen that those who don't utilize their mental faculties too much are more likely to be prone. So you need to constantly, it's just like exercising your brain. You have to constantly exercise your brain. But there we have found a lot of highly educated people also, highly qualified people also having dementia. So it's actually very difficult to pinpoint. But if you want to prevent it, yes, start now. Start doing a crossword every day. Start playing jigsaw puzzles. Start, doing some number games and or playing cards. These are simple tools by which we can actually do some brain exercise, or brain teasers as we call them, and thereby prevent dementia. We run a daycare center here in the city of Guwahati for dementia patients, and they are already having dementia, but still we do a lot of cognitive training exercises for their brains, and they do a lot of these exercises, and at least there are evidences, data to show that it can slow the prevention. If not, completely reverse, it cannot reverse it, but it can certainly slow the progression, not the prevention, but progression. But before having dementia, if you do it, you can maybe delay it.
Any medication for dementia? Coach Autu wants to know.
I would not say there is no medication at all. Don't start any medication just because some company will say that this, you have this magic pill and you will not have dementia. There's nothing like that. But your diet should contain adequate amount of vitamin B complexes. Vitamin B1 is important. Vitamin B12 is important. Vitamin C is important. Vitamin E is important. These are important constituents of your diet. So a proper nutritional counseling is important. So I think if you have a very good, holistic diet, you can keep it at bay. But there is no other medication that you need to take. Make sure you eat a healthy diet with adequate amount of fruits and vegetables and fiber.
Okay, Dr. Omar Kaing would like you to explore a bit more on the optimal utilization of resources at home.
Yeah. This optimal utilization of resources at home is that, see, every individual would have a different home setup. So it all depends on what kind of setup you have. So the person concerned or his family members are the best judge of how to keep this elderly patient healthy and active. So sometimes if you don't have, especially in COVID times, if you can't go out for, a walk or something like that, then you have to utilize the area in your house itself to keep yourself active. So try to reduce some clutter in your house. Try to see that you can get some more space for walking, ensuring that there's no fall in the process. If you have some steps, then you can do climbing up a few steps, say climb 6 steps and climb down 6 steps, provided your otherwise functionality is normal. If you have some wobbly gait, or if you already have some comorbid condition which does not permit you to do it, then do not do it. But if you're otherwise a healthy, elderly, then you can do some, stair climbing if you don't have a cardiac condition that is, and in your house. So that's why I said if you have staircases, they are good. You can utilize that. If you don't have a staircase, you definitely have a chair. You can do squats at home, squatting. There are different kinds of postures that you can ask train the elderly, like you have the squat. Yeah, so optimal utilization of resources is whatever one is the diet. You have to get get food always, from you don't have to buy junk food if you can grow your own vegetables at home. So I'm talking about those kind of resources. So if you have some space, little bit of space, you can start doing some gardening and have some at least get some vegetables which are organic, instead of having the processed food and other things that we get from the supermarkets. So these kind of things in the long run can be very damaging to our health. So we don't realize it in the short course of things, but in the long course of things, it can be very damaging. So that's
a number of patient people of the viewers are asking what would be the best treatment for lack of sleep and pain management. What would you advise?
First of all, lack of sleep. Again, we try to identify what is causing the lack of sleep. So very often pain. Pain is a very important factor for which a patient cannot sleep. So if there's pain, where is the pain? What is the location of the pain and what is the cause of the pain? So the treatment of that would be according to the site of the pain and the type of the pain. So, that needs to be dealt with accordingly. But sometimes, again, I am also trained in palliative care. And when we talk about pain, pain is actually not physical pain alone. Physical pain is only a small component of the total pain. So when we talk about total pain, we find a lot of patients who are having mental pain, you know. So the pain gateways in our body are such that, even if you are very stressed or very anxious or deeply uh, hurt about something, we all have had at some point of our lives maybe a heavy sensation in our hearts. We know what that feeling is. That so when you have those kind of something that's disturbing your mind, it'll manifest as pain. You will find that you can't perform because you are having some pain. I have had a breast cancer patient who was in her stage 4, and she was in severe agony. She was complaining of diffuse pain in her local site and all over the bone. She had bony mets. And then when our counselor did a detailed counseling of her patient, we found that one of her major concerns was the finances. So she was so worried about the financial implications of her treatment, and she didn't have any money, and she had a small daughter, and she said that all the money is going to be spent on my treatment, and there's nothing left for my daughter, and I'm anyway going to die. So we told her that, have you not activated the card? We have an insurance card which is given by the government. Have you not activated? She said that no, and she had the details, but she didn't know how to go about it. So one of our hospital staff coordinated that for her. And once she got to know that her treatment is free now, without she doesn't have to pay anything, her pain automatically disappeared. She didn't have any pain after that. She didn't complain of pain for the next few days at least, and she slept well. So I would suggest elderly patients for lack of sleep. The cause is very important. First, identify the cause and try to get to the root of it. But if you need to manage insomnia, then you should really start with very, very low doses of drugs. Like, say, suppose you think it's an anxiety. Most of them are anxiety related. Lack of sleep is because of some kind of an anxiety. And therefore, drugs like clonazepam and all can work well. Zolpidem and all also can work well because they are a little short acting. But very often, I think a lot of counseling and a lot of mental exercises and mental well-being state can be achieved and take care of sleeps. Just rather than I really am not somebody who commonly prescribes sedatives to my elderly patients. I really don't like to do that, except for patients with severe dementia who sometimes can be very violent. And when they reach that point, then we do have to restrain them with medicine.
Dr. Maype Tun would like to know, during COVID time, most of the elderly people are at home and they're not able to visit their children. So this may lead to mental status worsening. They're lonely, and how can we solve the problem? She would like to know.
So I think one of the best ways of those elderly who are alone and far away from their children is digital communication technology. This is the best tool by which we can bring them closer. And if the patient does not have that tool, we can have volunteers who can go and help them do that. If we have volunteers going to the older people's house and telling them how, connecting them through WhatsApp video calls or, any other platform to talk to their loved ones, at least say once in a day for half an hour in a day. So you need people who are keen to do that kind of work. And I think the community works best. The community way of working works the best in these kind of situations. Empower the community to take turns to go to identify how many elderly are there in this locality. Say there are 10 elderly. How many children are there who are doing nothing, in this COVID times? See if you can, get to connect. And these elderly, maybe they don't know how to handle phones. They may not have a mobile phone. But if anybody else has, then at least the youngsters also can go and help the elderly in communicating with their loved ones. So I think that's the only way out in these times, in these very difficult times. Otherwise, we won't be able to bridge that gap.
I think that's all with the questions. I think we've taken a lot of your time too.
Thank you so much.
Thank you, Doctor. But just a second, if anybody else wants to, any other questions from any of the participants who want to unmute and ask? If anybody has anything that we have missed on the chat, thank you. Everybody has appreciated your presentation, and thank you so much, Dr. Nilakshi.
Thank you.
Some of the doctors have asked if we can share the presentation. Is it okay?
Sure. Absolutely, absolutely. Because I believe in share. I believe in not keeping anything. There's no copyright to, all this work should be shared. I think. I have gathered through my experiences. There'll be so many other people also who gain experiences and learn so much, and I definitely learn from those people. So why should I keep my presentation to myself? It's all for others to learn.
Yeah, thank you. Thank you so much. And if there's any questions missed, if anybody wants to unmute and ask, it's fine. We will have another minute or so. But thank you on behalf of Global Pharma and the doctors from Myanmar. And thank you so much, Dr. Nilakshi. Thank you for the time.
It's my honor and pleasure. I'm so grateful.
Thank you.